All right. Okay, Dr. Deuk here, and it is July 7th, 2022. We're at the Deuk Spine Institute near Orlando, Florida, Melbourne, Florida, Space Coast to be more exact. And we're going to be performing cervical, because this is the cervical spine, Deuk laser disc repair at C4-5 and C5-6 on a patient with 2 herniated discs, which you could see on the screen in front of you. Luis, will you hold this here?
Of course.
This right here, this right here, this.
Oh.
Just rest your hand. Don't push down. And this patient has the C4-5 and C5-6 disc herniations that are quite large. They're pressing on her spinal cord and her nerves. So we're going to be going in endoscopically, and repairing them. You could see, if you count the number 2 bone, 3, 4, 5, 6, we're at C5-6. Our guide wire's in place. I need to take out the needle and leave the guide wire where it is. I'm going to use my x-ray machine to do that. I've got Jordan here working the x-ray machine. Now, there's a little kink at the end of the guide wire which is requiring me to pull. Don't bring your hand towards me like that, okay? You're going to get stuck by something. It's a rookie move. You let me move to where I need to go and drop, or you receive it once I stop moving. Okay? That's how people get hurt. All right. We've made a 4 millimeter incision in this patient's skin. 4 millimeters is tiny. I need to advance my dilator, which I can't even see, Jordan, because you don't have the bed right. You're pulsing. And when you do this, you have to make sure your guide wire tip doesn't go in deeper. We can go in about another centimeter, maybe half a centimeter from where we are, and we're okay, because this is a giant herniation. All right, And you got to be really careful as you advance your dilator along the guide wire. You can pull the guide wire back out, or you can push it in if you're not careful. I'm getting a lot of tension on the skin, and I feel like I need to make the skin incision a little bigger. Guide wire looks good. It is not advancing. It's staying right where I want it. I'm up against the front of the disc now, called the anterior longitudinal ligament, and I want to just check my AP view to make sure I'm near the midline. In the meantime, I might make the skin incision a little bit bigger. Are you going to the AP view? Do you see how Luis doesn't put his hand near my blade until I stop moving it? Okay, that's how you avoid injury. There we go, we're right in the midline. You got to do a better AP than that. Your spinous processes are off to your side. I think that might be better. It's hard to say. That's definitely better. So you can see the tip of the dilator is in the midline of the spine, in the front of the spine. That's exactly where we want it. You can also see the endotracheal tube and the esophageal temperature probe. All right. This surgery is done with a 4 millimeter incision done endoscopically. I have personally performed over 600 of these cervical ones, and we've reached, I think, 20 thoracic and and as far as lumbar goes, we've done about 800 or so, closer to 900 now. This procedure results in immediate elimination of pain from the disc. We call that discogenic pain. And usually immediate elimination of arm pain and arm symptoms from irritated or pinched nerve roots. All right. Now, we're not using any contrast, iodine contrast in this particular patient because she has an allergy to iodine dyes, 2, 3, 4, 5, 6. And we don't want to precipitate an allergic reaction. Now, for people that you really, really, really want to have, let's do the dye again, the blue dye. People that you really want to have, I need a pipe cleaner first. The iodinated contrast to see inside the disc with the annular tear, if you really, really want it, then you can do that. You have to do what's called a pre-medication with a steroid and Benadryl. But Shant, I'm not that keen to have a contrast dye study done. I've seen enough of these herniations, and we're going to go in there and get the job done. I'm just injecting a little of my blue dye, the Deuk spine dye, so I can stain the degenerated nuclear material that's herniated. All right, I'm going to advance the dilator a little more, Shant. Shot. Now, if you look at the MRI, you can see there's a massive herniation at C5-6. And there's another herniation at 4-5. And they're pushing on the spinal cord as well as the nerve roots. So I'm going to go in and take the whole herniation out with this tiny tube. And that's why we're using an endoscope to go down the tube. But the tiny tube makes it minimally invasive, and the endoscope makes it endoscopic. So this is an endoscopic, minimally invasive spine surgery. The name of this particular surgery is called the Deuk laser disc repair. And yes, that's the name of the procedure. It was developed here at Deuk Spine Institute by me, the founder and pioneer, and Shot. What makes this procedure unique is that it does what we call a decompressive discectomy, but it also, we do what's called an annular debridement. And it's actually the annular debridement that is what takes the neck pain away. Sean? And more importantly, it's the annular debridement that allows the disc to heal for long-term results. Because if you don't debride the annulus, then what's going to happen is there's still a hole in the back of the disc, and you're going to get what's called a recurrent disc herniation. And the rate of recurrent disc herniation is, in the literature, it's all over the place, but it runs between 5% to around 25%. So that means 1 in 20 patients having a surgery done without fusion. I've been having an open procedure done, up to 1 in 4 is going to have what's called a recurrent disc herniation, where they're going to herniate again. Nobody wants another herniation because that means you're going to have surgery again. Now, by the way, I have to say something. The literature is very deceiving because it reports between a 5 to 25% reherniation rate that gets surgery. But there's a lot of patients who reherniate and don't get another surgery. So that 5 to 25% are people who reherniate and get surgery. There's even more that reherniate and don't get surgery. So those numbers are really not entirely reliable. Now you should be aware of that. All right, the Deuk laser disc repair, 100% of the reherniations, they come back to me. Hey, what are we doing with the scope? And so I know all of them. I know all the reherniations because they let me know they've reherniated. And we've calculated that as 1% of the patients. It's around 1.1 or 1.2%. but we round it to 1%. That means 1 out of every 100 of these surgeries will reherniate. Okay? The good news is, because we haven't removed the ligaments or bones like you do in traditional spine surgery, we can easily go in and repair it. And there's no loss of stability of the spine. The biggest threat to destabilizing the spine is what's called iatrogenic instability. Now, some of you may have heard what iatrogenic instability means. It means the surgeon caused the instability with their surgery. And traditional spine surgeries do cause instability. Now, you don't want instability if you're a patient. And the way they cause instability is by removing bones and ligaments that are normal, that are in the way to get to the herniated disc. So the Koreans, South Koreans, not the North Koreans, the South Korean neurosurgeon, they came up with a way to get to the herniated disc in the neck, in the cervical spine, without removing any ligaments or bones and without destabilizing the spine. And I learned from them this technique 17 years ago. I had to go overseas to learn. And I've taken their approach, which is what you saw me do in the beginning. And that's how I get inside the disc, okay? Without damaging the spine at all. So I use their very minimally invasive approach, but then when I get into this disc, I do my own surgery, which is the Deuk laser disc repair. And they don't do the Deuk laser disc repair because they don't know how to do it. It's been peer reviewed and published, so they have access to it, but it was developed here at Deuk Spine, which is why it's called the Deuk laser disc repair. We got a problem. We have a cut wire. Okay.
I need a stripper.
We need a stripper. Louise, how dare you? All right, so what we're looking at while we're fixing the laser fiber is we're looking at the back of the disc where the herniation is, right down there. And that's all herniated disc right there. And you can still see some of the blue dye. I've turned off the irrigation, but I'll turn it back on. That right there at 12 o'clock, that lump, that globule is a piece of herniated disc. Below it is all the scar tissue from inflammation. And we've got a lot of work to do here, but our laser fiber is compromised, so we're going to have to repair the laser fiber.
Because there are two sizes.
All right, I'm going to try to grab that piece out. While Luis is fixing. Come on, you're supposed to wipe it.
Sir, did you check the laser, please?
What are we checking?
Is it on standby? Yeah. Okay. Thank you.
Use the same one.
Got it.
Careful, you're going to break this. No, you got to wipe it.
Seating.
If you have questions, by the way, I don't know if you can hear me, but if you have questions, we've had problems with our broadcast system. Our broadcast system went down. So the first surgery we did today, we couldn't broadcast, but we're trying to get it up and running, and we're hoping that you are all able to see and hear what we're doing here. That said, if you have questions, feel free to type them up, and Henry is going to notify me of the questions at the end of the surgery, and I'll be happy to answer those questions for you. All right, we've got our laser fiber fixed, and we're bringing it back down the laser, the endoscope. And we're going to get started again. Not too tight. You can't do this too tight because it cuts through the blue. Yeah, I just want to make sure.
All right, lights up. Thank you.
All right, let's try this again.
Hey, please, ready? Press ready.
You
over
can
here.
see the laser fiber has been repaired. I need the laser on?
Awesome, thank you. Yeah.
All right. You can see how nicely the laser breaks up this tissue. Now this is very scarred up herniation. There's a lot of scar tissue in here. That scar tissue keeps it clumped together. So we use the laser to release the herniations and remove the herniations because otherwise they just stick there.
That's okay, that's perfect. This one is perfect. Yeah, thank you.
And you can't get them out. So the laser is indispensable in these surgeries. It's not possible to get the results we need without a laser. A lot of people say, oh, lasers, you know, a lot of spine surgeons say lasers are not necessary, but because they don't do endoscopic surgery. That's like saying I don't need a hammer and a screwdriver as a veterinary doctor, but when you're a carpenter, you sure do. If you do construction, you do. So if you don't do this type of surgery, of course you're not going to need a laser. All right, so we're just plugging away here. This is the number 5-6 disc. And that little tail on the blue fiber is kind of annoying, Luis.
Yeah, I can fix that.
All right. Give me a second. A lot of scar tissue here. You can see it all. Very, very sticky. What that scar tissue is from what's called chronic inflammation. And what that means is that this herniation's been there for a long time. Scar tissue doesn't form that quickly, especially not large amounts like this. Scar tissue forms slowly, and the longer inflammation is happening, the more scar tissue will form. So. Are you able to get that tail off for me?
Yeah, I can.
All right, just give me a second. I'm going to come out.
Sarah, can I have some linings? Yeah, that one is fine. And then can you aim over here on the floor and then yeah, just my eyes is bad.
I'm asking Luis to get rid of that little blue piece of plastic coming off the fiber. Remember, the laser fiber is glass. It's the clear thing. The blue stuff is just the plastic covering over the fiber. Here. Light, guys, lights.
Can you aim over here?
Perfect.
Good?
Yeah.
Nice.
That looks good.
All right. I'm going to flip sides. Come this way.
Thank you very much, guys. Thank you.
Fuck.
Still there?
Yeah. So,
Let me try one more time. Let me have the laser.
take it out.
Lights on, please.
Can you turn off the light beam on the machine?
The light or
No,
The red light, the targeting beam.
There you go.
So we're having to strip the blue plastic around the glass fiber off because it's kind of piece of it sticking out, making it hard for me to see what I'm doing. Like I said, if you have questions about this surgery or
Again, light beam, yes.
spine surgery in general, anything to do with the spine care or the spine, feel free to ask it. I'm happy to answer it for you. Most of the answers I'll be able to give you, but there are some subject areas that I'm not an expert in, and I may have to research the answer for you. But we want to make this an interactive session where the viewer, you, the observers can ask questions. So that's why we do a live stream, and we don't just show you videos that have been edited. We show you the real deal, so you can participate and ask questions. This patient has traveled here to the Deuk Spine Institute from, where did she travel? Tampa, Florida. Wonderful. Oh, there's a big herniation right there. So she's here with her family, and they didn't want to have a fusion. She did not want a fusion.
She was struck by a huge tree branch.
Yep.
High culture.
Yeah, well, yeah. I'll just answer it later. So if you're asking questions, we have a problem. Laser. We have a problem with our sound system, and what I'm going to do, folks, and I apologize to you, we are going to get all your questions answered, I promise. But we're going to do that at the end when I come and sit face to face with you, okay? And the reason is that we just don't have the audio relay in place right now because one of our components is down. So I will get your questions answered, but later, okay? So please bear with us and be patient. I'm going to keep talking. So this patient had an injury to her neck. She got hit in the head, and she herniated her discs badly, and you can see that on the MRI. So she really needed the surgery done, but she wanted to avoid the kind of open surgeries where the whole disc is taken out, because the problem with herniated discs is never the front of the disc. It's never the back of the disc. I mean, never the side of the disc, never the middle of the disc. It's always, always, always the back of the disc. And so that's why the Koreans were so brilliant in developing a technology, endoscopic technology, where they actually left the whole middle of the disc alone. They left 95% of the disc alone, and just fixing the back little 5% that needs to be fixed, okay? So that's how much needs to be fixed, is 5%. So even though you're seeing big things here in the endoscope, this is really magnified quite a bit. So it looks big, but this whole field of view, remember that tube down there? That mouth of that tube is 4 millimeters. So from side to side is 4 millimeters. Right now I'm going out into the foramen on her right side. There's herniation here, you can see it. I'm blasting it away with the laser. So this would not be possible. This surgery would be not possible at all without laser. People talk about how laser is not needed. Well, that's because they don't do endoscopic surgery. If you do endoscopic surgery and you want to debride the annular tear, you must use a laser. The Koreans don't do this. They use grabbers only. And they've had so many complications by using grabbers. All they needed to do was use the laser. Just learn something from me. I took the laser, and it's normally applied for other areas of the spine, even the cervical, but I applied it endoscopically and I used it for the debridement. And that's what we're doing right now. It's called an annular debridement. And what's being debrided or removed is the herniation. So the annulus is not the problem. The annulus is the wall of the disc, and it's been compromised and torn through trauma. It's always trauma that damages the annulus and causes a tear. But the annular repair is only possible with the laser. So there's no other tool in the world that works. This is the only one. Lasers are expensive. They're expensive to buy. They're expensive to operate. And a lot of hospitals won't buy them because they cost so much money. But if you don't have a laser, you're not doing the surgery properly. Thanks. All right. So what we're looking at here is really the dura down there. That's the covering of the spinal cord and the back of the posterior longitudinal ligament. And that's just the layer right in front of the spinal cord. And you can see some of the PLL fibers there. And you can see that that's been compromised right there. And there's the dura. Oh, hope I didn't do anything. Ah, I did.
What happened?
A tip.
Okay.
Yeah, hold on. Yeah, the tip. Okay, I got it. But let me turn the irrigation off. We're gonna have to
Lights out again, please.
we're gonna have to do another stripping.
Lights and music, please.
We're doing a lot of stripping today. Is this still sterile over here?
Everything is on there, yes.
Yeah. Can you, I'm going to show you the laser fiber while we're stripping it. This is the piece we had to strip earlier and cut off. But you can actually see, can you see it? I know you can't talk to me, but there's a little glass. It's really half of a millimeter. So 0.55 millimeters, basically 50% of a millimeter glass. And then by the time you add the plastic coating, it's about a millimeter wide. So what happens is sometimes the sharp metal equipment will compromise the plastic or the glass. Remember, glass doesn't really bend much, so when you start to apply pressure to glass, it can deform a little bit, but then it's going to break. So as I was showing you the gap in the posterior longitudinal ligament where the spinal cord was, the tip snapped. So anyway, it should not have snapped, but it did, and we just had to fix it. All right. Again, I apologize I can't answer your questions right now because our audio relay is not working, but I will come and answer them later at the end of the surgery. Okay? And I'll answer them directly by talking to you. So the nice thing about this is that we can clearly see that we've gotten rid of a lot of the herniation already. There's a big piece right there coming out. So when we're done, Jesus, what is going on? I think we're okay. When we're done with the surgery, you'll actually see all that herniation is gone. And I talk about this quite a bit in surgery, but there's actually, a lot of people think herniated discs are one piece, but they're actually many pieces. As a matter of fact, for a lot of people, they don't have any symptoms for the first few herniations. It's only when the amount of nuclear herniation material gets significant enough that it causes so much inflammation or pressure on the nerves that it starts to create problems for the patient. They actually experience those problems and they get pain, they get radiculopathy or myelopathy, which is spinal cord dysfunction, like this patient has. And of course, when your spinal cord is being pressed on and damaged, you want to get that fixed right away. Why? I think the endoscope is getting stuck a little bit. Either there's some disc material or it's a little bent. All right, so once again, I apologize for not being able to hear your questions during this particular surgery, but we will get to them later and I will answer them for you. All right, now that said, another piece of herniation. Luis, I think these cables are pulling and torquing, so you gotta support the cables so they're not pulling on the scope. Yeah, that's better. Somebody needs to be helping me with that. All right, you can see some herniation there and scar tissue. That's the white cottony stuff right there. It's a lot of herniation. I think this is her bigger herniation, right? Luis?
Yes, sir.
The bottom one is the bigger herniation. There's a defect, huh? There, look at that, herniation just came out. Again, it's this
Oh, it is.
fluid cable,
Yeah.
okay? I need this addressed, guys.
Yeah.
You can't do this with that pulling on me. So you can see how nicely the laser vaporizes and eliminates the scar tissue and releases. Again, it's pulling. There you go. This is a bone spur. And then beyond that, herniation, scar tissue, foramen. There's a big herniation in the foramen right there. It is. That was literally sitting on the nerve. And I don't think that's the only piece, but so this is the neuroforamen for those neurosurgeons out there, orthopedic spine surgeons. And we're going out the foramen. We're in the axilla of the nerve root right there. And I don't see any more herniation. I just see a little bit of inflamed scar tissue. And we're not here to remove scar tissue so much, except when the scar tissue is holding a piece of herniation there, and that's causing pressure on the nerve or irritation of the nerve. So this is not a scar tissue surgery, but we do have access to the scar tissue. This is a remove the herniation and clean up the annular tear. You can actually see the end of the spinal cord, the lateral margin of the cord there, and this is going out the foramen. Again, I want to get as much of the herniation out as possible. I'm going to turn and go the other way. There's another piece of herniation. Yes? Are you talking to me?
No, Dr. B.
Oh. All right, so there was a lot here. I'm probably going to have to open up that PLL just to make sure that we're not leaving anything in there. So I'm going to do that in just a minute, because I don't want to leave a big piece of herniation in the epidural space out behind the PLL. That would be bad. Okay, so I don't really see anything in there. What I tell people is that most herniations are subligamentous. That means they're on my side, right where I am, inside the disc side of the PLL. Sometimes, though, you get a herniation that penetrates through, and you want to make sure you get it. All of it, if you can. And this is why you really want to be a neurosurgeon if you're doing this kind of stuff, so you can identify the neural structures. I don't see any herniation back there. So I think we've gotten it. I'm very happy with the results. I think the patient will be happy at this disc. I still have one more disc to do. I'm going to pull back a little bit and see if there's any more pieces of herniation sitting outside the tube. Again, I apologize. Normally we answer questions during the surgery, but because of our relay system is down, we're not able to do that during the surgery today. But feel free to type up your questions. Let's flip. and I will be there in about 25 minutes to answer them for you live. This is a live broadcast, by the way. We don't record and restream. We broadcast live. Why? Because we want people to see exactly what we do in the operating room. Now, sometimes things get tricky during surgery. You know, it's not always a smooth sailing, so to speak, and we need to show you how we solve problems in the operating room, because that's, after all, part of doing this surgery. You know, it's not always easy and perfect. We get a lot of situations that occur, and these situations create challenges that need to be fixed immediately in real time. And so I want the future generations of spine surgeons that I train with these videos, I want them to see how we resolve the problems. Because the problems of today will probably still be there tomorrow. So people need to know at least how I solve the problems with my team, with Luis and I. And Luis has been working with me now, how many years, Luis?
8 years.
8 years. 8 years. So he's the most experienced member of my staff in the operating room. And we have Oscar here as well, Jordan. And every one of them, and especially Jordan and Dr. Berndes, have helped me solve problems, real problems. There's a piece of herniation right there. So you can tell it's a herniation. It's nucleus, it's blue, stains blue, and it's smooth. So you can tell that there's been the effect of, why am I having trouble coming up? The effect of inflammation on it. Because what inflammation does is it attacks the herniations and it causes the surface to get smooth. It's like acid washing something. Okay? Your inflammatory system, when it attacks with enzymes, proteases. Okay, proteases, which break up protein into components like nucleic acids, and lipases break up fats, and of course sugar, complex sugars. So your inflammatory system, that's good, whatever happened there. The main cell in inflammation is called a polymorphonucleoside, PMN, and it's literally the most weaponized cell you have in your body. And it has bags inside of it called lysosomes that are literally chock full of very, very powerful enzymes, which basically break up proteins and fats and carbohydrates, which make up everything in your body. Everything in your body is made up of 4 macromolecules: proteins, carbohydrates, fats, nucleic acids, and then of course a lot of water. And those polymorphonucleosides contain very powerful enzymes that basically chew everything up. And by chewing everything up, there's your spinal cord right there. So just under the PLL is the spinal cord. You can see a blood vessel on top of it. So we're clear there. There's no herniation back there. I'm going to check the other side again one more time, and then we're going to be done here. So basically, your polymorphonucleosides come in during inflammation, and they just destroy everything. So when you look at a herniated disc, a piece of herniation, it's smooth because it literally has been blasted at the cellular level
Lights on, please.
by enzymes attacking it. Yeah, we're not ready yet. We have to do the irrigation, right? Oh, yeah, we're not doing betadine?
Yeah.
Oh, okay. Can I suck this out then?
Of course.
Hold that. So your nucleus, you got to ask, well, what is the nucleus nucleus propulsus made out of? And the answer is it's made out of proteins, what are called proteoglycans, which are polymers, chains of protein, and glycans are sugars, so proteoglycans. And the reason I know all this is, of course, I'm a biochemist. That is my degree in undergraduate from UC San Diego is biochemistry, cell biology, which is perfect for understanding the disease processes, because diseases affect, you know, tissues and cells at the cellular level. So anyone that wants to go into medicine and become a doctor or a researcher, I strongly recommend a very good, strong degree in biochemistry, cell biology. As part of the studies, you'll get some genetics and molecular biology, histology, which is the study of tissues. But almost all diseases operate at a cellular level. All right, I'm coming out with the tube, leaving the dilator in. I'm coming out with the tube. Shot. I got to watch my dilator. I want to make sure it doesn't go in any further. Okay, and I'm bringing the tube out. Shot. So you need to use the X-ray machine constantly during this kind of surgery, because you're using the X-ray machine, shot, to navigate your instruments, navigating, you know, using reference points, but you're also using the X-ray machine to localize to make sure you have the right place within the spine. All right, see this tube here is, we're doing the whole surgery through this little coffee straw. It's metal, surgical steel. It's all FDA approved, but basically it's 4 millimeters side to side. So when you look down the endoscope and see what I'm working on, it looks big, but it's only 4 millimeters. So, all right, shot. All right, so at this point, you could see C2 at the top, then C3, 4, 5, 6. We're gonna come out with the tip of this dilator out of the disc space at 5, 6. I'm going to plant the tip in the midline on the vertebral body of C5, and then I'm going to move up to C4-5. Everyone agree? C4-5 is next. So here we go. You can see the hole in the skin. It's tiny. Why are you moving the head? I don't want flexion. Shot. I don't mind inline traction, but I definitely don't want flexion. Shot. All right, here we come. Once I pop out, I can feel when I've popped out. Maybe I won't feel someday when I'm older, but right now I have good feeling in my hands. I'm out. And I got to make sure I'm in the middle of the spine. So you want to use alternating AP lateral views. I need to make sure I'm in the middle. By the way, you watch these videos and learn how to do the surgery. Doesn't mean you can do the surgery. You have to do hands-on, proctored, with me supervising you, lateral. And I can tell you right now, there's no surgeon in the world that has actually come here and been trained by me on the technique. So if someone tells you they're doing the Deuk laser disc repair, you don't believe them until they show you a training certificate that's not forged. 2, 3, 4. And we'll keep a log of everyone that I train at Deuk Spine. So if you ever want to know who have you trained to do this, I wouldn't trust anyone that says they're trained unless we have a record of them. Shot. This is the only surgery in the world done endoscopically that gets rid of neck pain or back pain or thoracic pain, because it's the only surgery that does what's called an annular debridement. The annular debridement is what gets rid of the discogenic neck pain or discogenic back pain. All right, looking good. We're moving up to the next disc, which is 4-5. Shot. All right, so I'm right over the disc at this point, but I got to check on the AP once again. I got to make sure I'm somewhere near the midline. You don't have to be dead center, but you want to be a centimeter left or right of the dead center. No more than that. Because once you go past that, you're getting into something called the longus coli muscle. And the longus coli muscle is not something you want to go through if you can avoid it, okay? The longus coli muscle, you don't want to go through it for several reasons. Number one, it bleeds. You don't want bleeding. Shot? Number two. All right, let's check the AP again. Number two, there's something in the longus coli muscle just running on the surface that you do not want to damage. So if you go through the longus coli muscle, you can damage it. It's called the sympathetic ganglion or sympathetic trunk, okay? If you damage it, your patient will have a Horner syndrome. You can look up what a Horner syndrome is. So damaging that sympathetic trunk will give your patient a Horner syndrome. Shot? All right, let's do a Coker AP. Everyone agree this is 4-5? 2, 3, 4, 5. All right, looks good. So you can see we're at the midline where we enter the disc, and we're starting to head off towards the left foramen back there. That's perfect. Doesn't get any better than that. Take this. I would like to do another discogram with my dye. Got to clean the schmutz out of the end. Shot. All right, that should have done it. We're going to use the dye now. This is not the iodine dye, so you folks will not see it on the X-ray picture, but you'll see it inside the disc. It's blue, if we get any. It's really hard to push it in because there's a lot of scar tissue. Shot. Once again, this patient's other option for surgery would be what's called an anterior cervical discectomy and fusion, or ACDF. Why don't we show our audience the difference between the Deuk laser disc repair and an ACDF?
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
First, I need an anesthesia record.
Crystal? Anesthesia record, please. All right, welcome back. I assume you all can hear me at this point. We ran a video showing you the difference between a fusion called an anterior cervical discectomy infusion, which is the most common treatment for herniated discs, watch the cable, in the neck, which this patient could have had a fusion done. She was offered it. She didn't want it. She wanted to have the disc fixed naturally without any metal or cages or bone graft or cadaver bone put in her neck. And so she came here to get this surgery done. This is endoscopic spine surgery. It's done here in the United States. The entire surgery is FDA approved and peer-reviewed and published, and it's safe and effective for treating disc injuries that are symptomatic, like cervical disc herniations, for example, or disc bulges. The Deuk laser disc repair is outpatient, meaning there's no hospital stay. So she's going to go home right after the surgery. It takes about an hour to recover, and then she'll be discharged. Our first surgery from this morning, we couldn't broadcast because our broadcast system was down. But I believe he's probably ready. There's a tear in the posterior longitudinal ligament. That's where the herniation can get into the epidural space around the spinal cord. But it just goes to show you how much trauma there was. Because to tear the PLL as well as the annulus, it takes pretty good amount of trauma. Every herniated disc in the human body is from trauma. Herniated discs don't just occur as part of aging. They require an injury. Okay? And I hear all the time, oh, I have herniated discs because I'm old. Nope. There are a lot of people who are old in their 70s and 80s that actually have all normal discs. Okay? Why? Because they never had an injury to their spine. They didn't get into a car accident or a fall or a sports injury. I get a lot of people who say to me, Dr. Deuk, I don't recall any trauma. And that's when I tell them it could have happened 10 years ago, 20 years ago, 30 years ago, you know, but it happened at some point. And a lot of people say, well, I still don't remember. And I say, well, listen, go on YouTube and watch something called Fail Army, and you will see maybe something there will kind of remind you of what happened. And if you've never watched Fail Army, it's basically a lot of just people with everyday activities who slip and fall or do sometimes stupid things in drunken stupor. And then, of course, they're not going to remember what they did 20 years ago when they were drunk and, you know, intoxicated and something happened. So, long story short, people get injuries, you know, and the most common, if you ask me, is a car accident, whiplash. And the problem is the insurance company that's responsible for paying for your medical care after a car accident, like State Farm, they're notorious for trying not to pay. They don't want to pay. They want to get out of paying. So they tell people, oh, there's nothing there, it's degenerative, or they send you to they approve an MRI place or a doctor that will just tell you there's nothing wrong. But honestly, there's an entire culture of physicians that just don't understand how the disc itself can be painful. So a lot of misinformation. And people end up being told there's nothing wrong, you have some herniated disc, but it's not causing your pain, when in reality it is causing their neck pain, or their arm pain, or their weakness, numbness, and tingling. So I can't tell you, I go a lot on social media. We have 100,000 patients we've seen since we started almost 20 years ago, and so many people are told by their doctors, their nurses, their chiropractors that there's nothing that can be done other than therapy or pain pills, shots. But we can now fix people's pain, you know, with the Deuk laser disc repair and the Deuk plasma rhizotomy procedures, targeting the disc, targeting the facet joints that are painful. The key is to make the right diagnosis, and that's something that most doctors fail to do. They don't make the right diagnosis, you know. They don't know how. They don't have the tools to do it. And that's one thing that sets the Deuk Spine Institute apart, is that we're able to figure out where people's pain comes from by looking at their MRI and by doing an exam at the same time as we're looking at the MRI. But you got to have both. You can't do it just based on an MRI. You got to be able to examine the patient and see where their pain is coming from exactly. Like literally they have to put their fingertip on the worst area. And I ask that of every patient I see that has pain. Where is your worst pain? Put your, oh, there's a herniation. Oh, that was a herniation in the foramen. Wow, that was big. Try to get it out. We have a name for those. They're called reverse herniations because it's a piece of herniation that is outside the disc. No, I can't get it. It's too big. I'm gonna have to break it down with the laser. It's and it's was herniated, but then it's now coming back into the disc. But instead of going into the disc, we're trapping it into the tube that we're using here, to the endoscopic tube, tubular retractor. So I'm breaking it up into smaller pieces right now with the laser, and so that each of those smaller pieces can float out through the top, like those right there, just floating them out. So the laser is quite wonderful. We wouldn't be able to do the surgery without the laser. It's so important. It's impossible to fix people without this laser with the endoscope. Anyway, there's still herniation here. I'm cleaning it out. It's pretty scarred up. It looks like it's been here for a while. That's the yellow color. You can see the border of the spinal cord there. I'm literally right on the spinal cord here. So we have to be very careful. People ask me all the time, how do you know, how are you careful enough? Well, it's training. I'm a neurosurgeon, first of all. And of course, as a neurosurgeon, I'm trained to operate around the spinal cord and not damage it, so, or the nerves for that matter. That's my job. But the laser makes it possible, okay? Because the laser is so precise. All right. May have some herniation there. We're going to have to see. I'm going to have to peel back some of these layers and look. I don't see anything. By the way, the white is probably the dura of the spinal cord, the covering of the spinal cord, and that's why we do the dye injection, because the dye will stain herniation blue. And you will actually see blue down there when there's a piece of herniation. But I've gotten all the herniation out. I don't see any more. I don't see anything. I'm going to just look a few more times and make sure. But doctor, we're almost done. 5 minutes. Now, go ahead and type up your questions. And by the way, if you have not seen our app or our website, I recommend you visit DeukSpine.com. We have a lot of great information there, and our app is wonderful. It's free. It's on the Apple platform, but it's also on the Android. And it's really, I think, useful. So check it out. All right, this is going out the foramen. I'm going to do this and we're done. Yeah. This should be it. You can see how the herniation is stained blue though. Okay, you see what I'm talking about? That's that Deuk spine blue juice. No, we're done. Have you already opened it? All right, it's fine. All right, go ahead and switch then. No problem. Let's just look one more time. I don't see anything. I think we're good. It's just, no, just some word of advice to surgeons and doctors. Don't gild the lily. You're never going to get a perfect 100%, all the disc material gone. So don't try to get 100%. Always try to have the best results, but sometimes when you push it too hard, push it too much, you go over and you create problems. You don't want to do that. Not with spine surgery. Is the irrigation on? All right. There's just some pieces here I want to get out, and we're done. These are small. Let me try to grab it out.
We can if you want, yes.
That's why I always look around. If you watch enough of my surgeries, you see me looking around. I don't just look once, I look like 3 times, 4 times, because as you move the tube around a little bit, sometimes you get a piece of herniation that was hiding behind the tubular retractor and it pops out. There's one. All right. We're done.
All right.
Great job. Hope you enjoyed watching, but feel free to type up your questions. I'm going to come answer them in about 8 minutes. And for those of you, can you see this here?
Yes.
Can you see this?
Yes.
I hope you can see it, Henry. But this is her chin, her face. She's asleep. Her chest is here. So we're going right through to the spine with this tube. And just to the back of the disc, and that's where we do the whole surgery. Again, for those of you wondering, this is FDA approved and peer-reviewed and published. So it's the highest standard, highest quality type of spine surgery. This is the future of spine surgery, by the way. There are 2 million fusions now being done this year in the United States alone, and probably, if I had to guess, 4 or 5 million worldwide. All of those spinal fusions, about 95% of them will go away and be replaced by the Deuk laser disc repair in one form or another. Show them the incision, Luis. Yeah, take a look at the incision. It's 4 millimeters, tiny. And fix 2 herniated discs with that. Great job, everyone. Yep. All right, why don't you show our audience, Henry, what the Deuk laser disc repair is, so they could understand it through the animation. And I'll be there shortly to answer questions.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, Submit your MRI for a free review at www.mri.dukespine.com.
I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck, and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything's gone. A little soreness in my throat, my voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
This is Dr. Deuk. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. It just took a long time to recover from that. So this was much, much better.
Your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
of
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries, he puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
Surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
Just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, 2 of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70 degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees,
nice.
and then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery.
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because you know, we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. All right, I'm here with one of my patients who traveled from Australia to Florida to the Deuk Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone
Awesome.
from the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Deuk laser disc repair.
I had the Deuk laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Deuk laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Deuk. I found Dr. Deuk, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and the loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And it's not really, about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Duke Spine overall?
Oh, it's really good. Staff is really welcoming, and it's spot on, and they receive you with a smile, and which is really great. And my father was telling, oh, it's amazing how he never thought that in American health system, people like the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool. I should say, yeah, they're welcoming. They're good.
Thank you very much.
And you are the best. I
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is like a very good cutting edge technology and very advanced surgery, which Dr. Deuk has developed his own, and without minimal, no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without, manipulating any of your muscles or anything. And you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complications from the surgery, this is the best surgery you can get done by Dr. Deuk here.
Congratulations once again.
Thank you, doctor.
Thank you for joining us. I'm Dr. Deuk, and we have just finished a anterior cervical endoscopic surgery. And the name of the surgery is called the Deuk laser disc repair. You may not have heard the name before because it's not something that your surgeon will talk to you about, as they don't know how to do it, except for maybe Dr. Tripathi, who's in India, who's now following my surgeries and understands the benefit of this type of technology. Look, most people with herniated discs in their neck, they're going to be offered this treatment. This is a metal plate, and this is the cervical spine. You really can't see it well, but behind the metal plate, are you able to see the cage there?
Yeah.
There's a cage there. And the reason there's a cage there is, and this here represents the anterior longitudinal ligament, and then this is the posterior longitudinal ligament. So there are two longitudinal ligaments. They run from the top of the spine down to the bottom, the ALL and the PLL. And just behind the PLL is where the spinal cord and nerves are. So most spine surgeons, when they do fix a disc, a herniated disc in the neck, they go through the front and quite literally they cut the entire ALL out with a scalpel, and then they scrape with curettes the disc out. They just scrape the whole thing out, so that when they're done, there's literally, and I'm going to show you a bigger model, all of the disc here has been removed from between the bones, and there's a gap there, and that gap, you just can't really leave a gap between the bones unless there was no real space there to begin with. If somebody has a bad degenerative disc, then the bones are on bone, and you just go and you go through there and you clean it out and you take the herniation out in the back. But most people still have some disc there, and once you take the disc out in the front to get to the herniation here in the back, you're left with a space between the bones. And so what we do in modern spine surgery is we put something in that space to give support to the spine. And that something used to be a cage, like a plastic or metal cage, or even a piece of cadaver bone, or even a piece of the patient's own bone, like iliac crest, which is basically you'd have to flip the patient over at the beginning of the surgery, and you make a cut over their iliac crest, and you take out a tricortical piece of bone. You literally chisel away a rectangle of this bone in the pelvis, which is bad, and you take it out, you put it in a bowl, and then you put it into that space so you could fuse. That's what we used to do many, many years ago. It's still being done in places. It's not good because it hurts like hell where they take the bone from, and it doesn't really hold support that well. So over the last 20 years, there's been a development of manufactured, sturdier, with a higher, what's called a modulus of elasticity, bulk modulus of elasticity, a stronger implant that holds its height and keeps the space open. And those are what are called PEEK, P-E-E-K cages, or titanium cages. And the other thing we used to use 20 years ago was basically a piece of cadaver bone, a dead person's bone that's been cleaned and processed, a fibular graft. It's a little ring of fibula, and you could pack bone graft. The problem with those is that they get absorbed over time, and then it causes a collapse. So then the spine shifts from lordotic to kyphotic. I never use those cadaver bones. I used them 20 years ago before PEEK cages came out. But now that there are PEEK cages, that's what I use. I don't like the metal cages because they're too stiff and they cause fractures of the end plates. Long story short, if I do an ACDF, which I will be doing one in a couple of weeks, as a matter of fact, yeah, I'm going to be using a PEEK cage. All right. But this surgery today that you watch, we didn't use a PEEK cage. We actually went through the disc endoscopically all the way to the back where the herniation is, and I used the laser to remove the herniation. And I left the disc alone, and so this patient has a natural repair called the Deuk laser disc repair. So the reason you won't hear about the surgery is because your surgeon doesn't know about it and they don't know how to do it. But it's the most advanced spine surgery in the world for herniated disc, bulging disc, degenerated disc that cause symptoms. All right, we're going to go to our questions now.
Alrighty. First one comes from Santosh.
This first question is from Santosh on Facebook.
And they asked, first question is, do you always cut PLL and expose dura?
Santosh, great question. I believe Santosh is a spine surgeon. I'm not sure, but welcome to the broadcast, Santosh. Santosh is a spine surgeon in India, I believe, or Pakistan. I'm not sure which one. I apologize. Long story short, I do not always go through the PLL. So what I have found is that the majority of herniated discs in the neck do not go through the PLL. They're what are called subligamentous herniations. And let me explain this. If you take a normal disc and then you tear the annulus and you get a herniation, whether it's a grade 1, 2, 3, 4, or 5, there are 5 levels of herniation. Level 1 and level 2 never cause problems or pain or symptoms. We don't deal with them. Nobody operates on them. Level 3, 4, and 5 are everything from a disc bulge that's contained, which is really a level 3, to extruded disc, which is a level 5. And level 4 is by far the most common, where the herniation has gone completely through the annulus and it sticks out a little bit. Now, when it sticks out the back of the annulus, it hits the PLL, the posterior longitudinal ligament. Some of those herniations pass through the PLL and then they're up against the spinal cord in the epidural space. But the vast majority, 95% of herniations are through the annulus, but they hit the PLL and stay below the PLL. So when I go in with my laser, I am zapping it away, and then I get to this PLL and I don't need to go through it, okay? But sometimes I'll see a herniation that passes through the tear in the PLL and it's out here in the epidural space against the spinal cord. Those, I use the laser to open the PLL, and it's literally a millimeter and a half thick, maybe 2 millimeters because it's swollen from inflammation. And I get there and I open the PLL with the laser, and you can see big chunks of herniation outside the PLL against the spinal cord. And I can then use the laser or grabbers to extract those. So the answer is I do not go through the PLL unless the MRI shows me a massive disc extrusion that looks like it's gone through the PLL. So ahead of time I know that. Or I get in there with the endoscope and I see a tear in the PLL and I see herniation on the other side. You can see it through the crack. So I like to look through those cracks in the PLL, the tears, and I like to see, is the dura down there? I can tell if it's dura because it's white and it has some veins on it. You can see the veins are on the dura or little arteries, and you know that's the dura because herniated discs don't have veins and arteries. And plus my herniated discs are blue. That's a long-winded explanation, but it's a great question.
Right. Next question is also from Santosh, and they asked, what's the end point of the cervical endoscopic repair procedure?
Santosh, Dr. Santosh, I believe, is asking what's the end point of the anterior cervical Deuk laser disc repair? When do I know I'm done? So I make it a point to always go foramen to foramen. You could see that during the surgery. It's very easy to move the endoscope from side to side because it's pivoting from the center. It's held in the front, but it's allowed to sweep from side to side, just like that. And I'll go for foramen to foramen, and I'll look along the entire back of the disc. So when I look at the foramen and it's open and empty, there's nothing inside like a herniation on both sides, I'm done with the foramen. When I look at the middle of the disc, the middle of the back of the disc, and there's no herniation and I can see the PLL, I know I'm done. Or if I know I have an extruded disc, I go through the PLL, I remove those fragments, I can see the spinal cord now, there's no more compression. So it's very easy to tell when you're done endoscopically. And the last question you had was specifically what endoscope do I use? It's a very good question. Unfortunately, it is a Wolf endoscope, but Wolf stopped making it in their stupidity. So what they've done now in the last 5 years is they have a new cervical scope that was actually designed by Dr. Stefan Hellinger, a German, who was one of my instructors in teaching me the endoscopic technique in the neck, along with the South Koreans, Dr. Seng-Ho Lee and Dr. Gun Choi. the Koreans developed the fiber optic scope for Wolf, and that was Dr. Seng-Ho Lee and Dr. Gun Choi. Then Dr. Hellinger in Germany, where Wolf is manufactured, of course, and based, he thought that the fiber optic scope, because it's got 5,000 fiber optic fibers, didn't give as good of a picture as a rod lens scope, which is true. Rod lens scopes have lenses rather than fiber optics to transmit the visual image. Therefore, they have a better image. So Hellinger developed a rod lens scope for the cervical spine, but it's much bigger, fatter, and it's shaped oval, which I don't like. Anyway, that scope is the one that Wolf is promoting. So Wolf refuses to produce any more of the fiber optic scopes. I bought all the ones I could find, and I have them here at Deuk Spine. So that's why you're not finding them. It's not because I bought them all. I only have, I think, 8 of them. But Wolf will not sell them anymore, and Wolf will not manufacture them. So if you can get Richard Wolf to do that, great. I'll buy some more.
Right. Next one comes from John. This isn't a question, but it's really sweet. Being able to learn from you and your team is an honor.
Thank you, John from Facebook. I appreciate the comment about learning from us. That's why we're here. Look, there's things in life that we can see with our own eyes and we can make judgments on. And then there are things that we have to rely on experts. And I'm dealing with an issue right now at Deuk Spine where I have to rely on experts. That is, our network crashed from one of my employees who didn't do his job, and he destroyed our network. So we've been without email now for almost 2 weeks. I don't know anything about networks. I know very little. I could not fix it. So I have to rely on an expert. And I trusted our network administrator that we hired and paid a lot of money to. But he let us down because he didn't do anything to maintain the network. He didn't know what he was doing. And I found out that he was spending my money to hire consultants to try to help him. And even then, he failed miserably and destroyed our network. My point is this. In healthcare, people are in the same situation. They don't know where to go. They don't know who to believe. They rely on, word of mouth. They rely on kind of where is the bar today, And unfortunately, most doctors will tell you fusion, okay? When I started 20 years ago, I was one of the few fusion surgeons in the United States. There were about 5% of spine surgeons were doing fusions. This was back in 97. So it was, 25 years ago. Back in 97, most spine surgeons were doing what's called a laminectomy or a microdiscectomy, or a laminoplasty, was a newer technology then. And those are all non-instrumented procedures, but the problem with them is they don't address the instability of the spine that's created by the surgery itself, okay? Not the instability that exists before the surgery, but a new instability created by the surgeon cutting the muscles and tendons and ligaments and making holes in the bones to do the laminectomy, laminoplasty, or microdiscectomy. What I'm getting at is, in the last 25 years, there's been a transformation in spine surgery to where now we've gone from doing 95% or 90% non-instrumented surgeries, which are laminectomy, microdiscectomy, laminoplasty, shifting to laminectomy plus fusion or laminectomy and artificial disc. Okay, so artificial disc surgery, basically implants going in. Okay, so I started learning laser surgery, endoscopic surgery 17 years ago. And I've been doing it now for almost 17 years. So while the rest of the surgeons are learning instrumentation techniques that I learned 25 years ago and applied 25 years ago in my practice, I have transferred from metal and fusion and screws and rods and plates over to less invasive endoscopic surgery. I have no doubt in my mind that fast forward when people get their heads on, people are educated about what their options are, people aren't going to want metal in their bodies anymore. They're not going to want this stuff. And I don't want to put it in because I know that natural endoscopic Deuk laser disc repair is far better than putting metal. The metal is totally unnecessary. It doesn't do anything to fix your problem. It's totally unnecessary. The only reason metal is necessary is to fix what the surgeon creates during their surgery, the instability. The surgeon goes in and literally drills holes and removes ligaments and destroys muscles and kills muscles, and all that causes the need for fusion or artificial discs. Okay, so people are getting metal put in their spines only because the surgeons don't know any better. Now there are surgeons who know better and still choose to do it that way. And to me, those are bad actors. Those are bad people. You don't want to deal with them. You want to get away from them. So at some point, when enough people in the world know about these surgeries that I do, the endoscopic surgery in the neck or the back or the thoracic, they're going to demand it from their doctors. And when they start demanding it from their doctors, the doctors will be forced to learn it. Until then, the doctors will keep putting in metal. Why? Because there's so much money being made putting this stuff in by the hospital, by the doctor, by the surgeon, by the implant company that manufactures it. Billions and billions of dollars. Billions. Okay? If you think about it, there are 2 million fusions done a year, and the average amount of money paid for metal for each of those surgeries is around $10,000. That's average. So what's 10,000 times 2 million? So 100 times 2 million is 200 million. Then there's 2 billion, and then there's 20 billion. So the number's right there in front of you. $20 billion a year industry, metal. Metal, metal, metal. That's the United States alone. 20 billion. Do you think the people getting those 20 billion, those greedy bastards that own the companies, do you think they're going to give that up for a guy like me because it's the right thing to do for people? You know the answer. It's not going to happen on its own. This has to be a grassroots effort. Human beings have to realize they're getting fucked by the system hard, and that if they don't want to get fucked anymore, they're going to have to fix it. I can't fix it. I'm one guy. I don't have enough money. I don't have enough political clout. I just do surgeries and I teach people. But you guys are the ones who are going to have to fix it, not me. Okay, I will help you any way I can. But we run a small business here, a small medical clinic. We have 5 doctors. That's it. We got 60 employees. We're not the Cleveland Clinic or Mayo or Kaiser Permanente. Shame on those guys for perpetuating the metal myth. They should be embracing less invasive technology. And yet, I have people that come here from all over the world because they can't get the endoscopic surgery done that we do here, okay, in their country. And they come from all over the United States too, because American surgeons, spine surgeons, aren't doing this stuff. They just want to keep putting metal in. That's the best answer I can give you, and I know you didn't ask me a question, you just gave us some praise, so thank you. But that's why I do what I do, because I want enough people to learn the truth. Once they know the truth, then someone can fix it. I'm a big believer in the matrix theory, right? That here's all these people plugged into this false reality, this lie. People suffering with neck and back pain, believing that it can't be fixed or that they need metal to fix it, whether it's an artificial disc or fusion. It is a lie, okay? And one of these days, I'm gonna wake up Neo, and Neo is gonna be like Elon Musk, for example. All right, poor Elon Musk. He's already had how many surgeries on his neck? I think 2 or 3, okay? That guy's gonna need another surgery. Why? Because he got metal put in. He's gonna get adjacent segment disease. Someday, if Elon Musk can figure out what it is I'm doing here, and he can see the benefit of it, maybe that guy, Elon Musk, will open his mouth and use all the resources he's got to make a difference in the world. You know, yes, electronic vehicles are wonderful. Space travel and research is wonderful, but the world is sick, and the most common reason they go to the doctor is back pain and neck pain, and we can cure it now. Every single person, I believe we can cure it. It's just a matter of learning for each person what their pain is coming from, whether it's disc, facet, both. There's a few other causes, but we need somebody who wants to help people get out of their misery and suffering and stop putting metal in people. We need that advocate, and that person can help change everything. So, any more questions?
Final question. And this comes from Carrie Sutterer on YouTube.
Hi, Carrie on YouTube. Thanks for asking.
And they said, hello from Perryville, Missouri. I had a level 10 fusion. Have you ever performed one, and what is the recovery time? I'm struggling immensely.
Yeah. So, Missouri.
Perryville, Missouri.
Perryville, Missouri. I've been to Missouri. I love Missouri. It's beautiful. A level 10 fusion. I assume what you're talking about is 10 levels fused. It literally breaks my heart to hear that. I don't know why anyone would need a 10 level fusion. I've seen them, and the only reason I can think of that I've seen why people need a 10 level fusion is, honest to God, there's two reasons, but one that comes up all the time is their surgeon had to make some kind of payment for their Mercedes. Look, I don't even drive a Mercedes, I drive a Volvo. The other reason is something called juvenile scoliosis. It's basically bad curvature of the spine in kids, and that needs surgery to correct the curve and keep it from getting worse. But most people get fusions like this for what are called degenerative disc disease, rarely trauma, like a fracture dislocation at the thoracolumbar junction. But I assume, based on your comment, you had your 10 level fusion for degenerative disc disease like herniated disc, bulging disc, maybe some scoliosis, but you don't need to do fusions for those anymore. We fix all that with the laser surgery. So I don't know what to tell you about whether you need it or not, but as far as your recovery goes, I'm not surprised you're having trouble, because when a surgeon does a 10 level fusion, they literally have to peel the muscles off your spine and move them over across 10 levels. Now, the surgery alone for a 10 level fusion must be at least 6 hours, 8 hours. If I did a 10 level fusion, I could probably do it in 2 or 3 hours, but most surgeons take 10, 12 hours to do that surgery. The problem is when you peel the muscles off the spine and hold them open, they're not getting any blood flow while they're retracted. So they're dying. And so what's happened is your surgeon has killed all your muscles on your spine. And that's where all the pain's coming from, is dying muscle. And muscles die over months, quite literally months. They slowly die. And as they're dying, they release chemicals that hurt really bad. So I'm sorry you're suffering. I really do hope that the pain passes quickly. I don't know why you would be hurting other than the muscles, unless there's something wrong, like something's broken, a broken screw, broken rod, something's fractured. Some people do get fractured bones after fusion. So I would recommend you go back to your surgeon and tell them you're in pain, and let them get some x-rays and maybe a CAT scan or MRI and see what's going on, okay? And I'd be happy to do a free MRI review. We have our own free MRI reviews for anybody that wants it. You don't have to treat with us. You don't have to come here. We will be happy to look at your MRI and try to figure out what's wrong with you and tell you. We do MRI reviews every week, and about a third of the patients end up coming here for surgery. We offer surgery pretty much to almost everyone that needs it. 2/3 of the people just get the advice and they're done. They just move on with life and do whatever they do. So You're welcome to utilize our free service, free MRI review. It's mri.dukespine.com. Just go to our website, and I'll be happy to look at your images. But you know, without imaging, without either X-rays or MRIs or a CAT scan, it's impossible for me to know exactly what's wrong. I'm just guessing on the muscles because that's the most likely thing that causes pain. And that's in a case where you don't have anything else wrong. Okay? Any other questions?
That is it.
Thanks for watching. I'm Dr. Deuk. We'll be back in about 30